Morning and welcome to Boston Outlook. I'm your host, Julee Marra. On the line with me this morning is Dr. Mark Souweidane. You have quite an impressive title, and before I jumble it all up, I'm going to let you introduce yourself, Doctor.
Well, good morning, Julie, and thank you. I am the Vice Chairman of the Department of Neurological Surgery at Weill Cornell Medical Center and New York Presbyterian Hospital. I also serve as the Director of Pediatric Neurosurgery at Memorial Sloan Kettering. It's great to be with you today.
Thank you so much for being here. I know this is probably your day off, but I understand that, you have actually done over a decade of research and testing for alternative therapeutic delivery systems for inoperable brain cancers in children. Is that correct?
That is correct, with one minor correction, and that is it's been about 2 decades worth of preclinical research.
Wow, my info is inaccurate. Okay, so over 2
right.
decades. Yeah. Wow, so over 20 years. So, kind of give us the cliff notes of what you've seen from the beginning to present day.
Yeah, there's many stories to be told, but understanding we have some limited time. I was very drawn to the realm of what's called translational research, just to help optimize and improve some of the outcomes of these children with otherwise terminal cancers. Frustrating from a surgical standpoint, frustrating from a neuro-oncologic standpoint. So really my introduction into the realm of translational research was governed out of frustration and watching these children die, while other children with tumors in different locations or other organs would be invariably cured. And that was the attraction.
So 20 years ago, the research must have looked a little bit different than it does here in 2017.
Oh, my goodness. That's so different. And not just the research, but what's available to us today. And really what has been very enlightening is to watch the evolution of technology, of device manufacturing, drug discovery in that same time period when some of these tools or most of these tools weren't even available when I got into the idea of what's called local drug delivery for pediatric brain tumors.
So where do we stand kind of with, the number of children who have been diagnosed with brain tumors?
Yeah, the interesting thing about the epidemiology and the incidence of brain tumors in children is certainly within my career and 30 years prior to that, we've been seeing a decade-by-decade escalation in the incidence. While the overall numbers aren't great, we're talking about, for certain types of tumors, or a couple thousand a year in North America. What has happened in that time period is an increase in the incidence. And this is a departure from what we've seen with other cancers in children, where the rate of increase is definitely higher than it is in other organ systems. And the other aspect of this is, in that same time period, if you look at the success of therapeutic approaches toward children's cancer, we've watched an ever-increasing rate of improvement and benefit for children with other types of cancers, common ones being the leukemias, the neuroblastoma. And these types of diseases, we've watched a fairly steady decrease in the mortality rate. And although we've seen that in pediatric brain tumors as well, again, the rate of benefit or that attenuation of that survival curve has not been as good as it has been for other organ systems. So we're seeing this parallel of increasing rate and a slower rate of improvement or benefit with therapeutic approaches. So we have our work cut out for us with regard to pediatric brain tumors. There's no question.
So when you say alternative therapeutic delivery systems, what does that actually entail?
Yeah, it's a great question. The conventional wisdom is that you would give and do give chemotherapeutic agents by way of either an oral intake and most commonly an intravenous intake, so something that's given in the vein. These chemotherapeutic agents, while they can be very effective, they circulate through the entire body and affect the tumor in a way that is governed by how much of that tumor can come out of the bloodstream and into the tumor itself. In the neuro-oncology, or in the field where we deal with brain tumors, that fraction of drug that gets out of the bloodstream and into the brain tissue and hence brain tumor is very, very small. And it's usually governed in single-digit percentages relative to what we see in the systemic circulation. So that is a very inefficient process as far as getting drugs to our target organ. So alternative forms of delivery, and what I have focused my entire career on, is a concept called local delivery, where rather than giving it in the bloodstream, we go directly to the tumor by placing, in this particular sense, small devices, small, tiny hair-like catheters into the tumor and infusing the drug directly to the source. This has two huge benefits. One is you get very, very good concentrations of drug in the tumor. And the other parallel benefit, concomitant benefit, is the fact that we're getting virtually nothing in the systemic circulation. So you avoid all the limiting aspects of giving drugs in the bloodstream and hence suppressing bone marrow and end organ failure, et cetera.
Right. And, it's funny, I actually just had a separate segment earlier this morning talking about, women who are cancer patients and how salons locally are giving red carpet makeover experiences to them, and how really the chemotherapy, it doesn't differentiate between healthy cells and cancerous cells. So women are coming in with loss of hair, loss of nails. Their skin is much different than what it was pre-cancer diagnosis. So to get this type of treatment and therapy directly to the source, so to speak, kind of alleviates that whole body experience and whole body side effect of those chemotherapy drugs.
Yeah, and what you see in those women is the common appearance of what a cancer patient looks like, right? And that's what's obvious to the outside observer. Now understand that, as you mentioned, there's no selectivity of those agents, by and large. That's not necessarily true in every situation, but most conventional chemotherapy attacks a cell that is rapidly dividing. And that can be a hair follicle, hence we see individuals who lose their hair. Most commonly the bone marrow, and the bone marrow is a very important organ for replenishing red blood cells, white blood cells, the cells that ward off infection. So internally, there is also there's havoc that's wreaked on the body from the standpoint of the toxic effects of chemotherapy. And most of the time we're very limited as far as giving the appropriate therapeutic dose of a chemotherapeutic agent because of the toxic side effects. And that's usually a limiting factor as far as effectively treating cancer cells. You can't give a certain drug in a certain concentration as much as you'd like because of the toxic side effects. And with local delivery, that element is essentially eliminated.
Mm-hmm. Right. So, how many children actually have been treated with these alternative therapies?
Well, I'll back up a little bit and say that the concept that I just outlined is very appealing and very tempting. And when I started this in probably 1995, 1996, as far as a conceptual backbone, I literally thought it'd be 1 to 2 years before we could translate that concept into a clinical trial for a very specific type of tumor in children called a pontine glioma, or diffuse intrinsic pontine glioma, the acronym being DIPG. The reason we chose that tumor is because of its relatively small size and this idea of locally administering a drug might be more easily obtained. And then the other is because 100% of these kids will pass from that disease with a median survival of just under 12 months. So, but that transition from concept to clinical application took me nearly 16 years. We launched our clinical trial using that concept for this particular disease, DIPG, in 2012. And for something that had been reported worldwide, this is a feasibility issue in 4 patients. We have now performed, I think, 35 treatments and somewhere about 28 or 29 patients.
Wow.
And what we've done with that, as most oncologic trials, early phase clinical trials do, is you continue to give a higher and higher dose insofar as those children tolerate it, in an attempt to find a dose that works or doesn't result in injury.
Right. Right. I mean, so there's so much going into this because you're learning as you're administering the therapy. So it's that fine balance because you're dealing with somebody's life, right? I mean,
oh my gosh, you've touched on no question. You touched on a very, very important and ethical aspect of doing clinical trials. You want information, but you also want to provide the best therapeutic approach you can to a child. So there's always that push and pull, that fine line you work in, that basically, as much as I'd like to give more drug or repeated drugs, you first need to start with stepping stones. So you've got this dilemma of, can we do this? And it's really underscored by defining it in a way based on everything we know from the preclinical research and other laboratory research in a realm of safety. Mm-hmm. So if I've done, and if we've done as a community our homework with regards to safety, and that's the place you start, and you work within incremental steps in the hopes of not hurting individuals along the way. That's a dilemma for the clinician. You can only imagine the dilemma for the parent of one of these children.
Right, I know.
Do I subject my child to something that's novel and innovative and different with some risk versus not?
Right. And, I mean, my brother's best friend, he had a form of sarcoma, and this was going back in the mid-2000s. And, he was kind of like one of the pioneers for young adolescents and young adults that are going through treatments right now in 2017. They've set up a foundation. They're doing clinical research and trials and so forth. And to think, I mean, yes, although my brother's friend lost his life, his legacy was able to continue because all of the treatments that he had gone through were kind of, like you said, those stepping stones to kind of build where the research is right now in 2017. So
yeah, you touched upon a very impressionable aspect of clinical trials. Every one of these parents who have come to me with their child who is assigned a destiny of death come to it with an amazing degree of fortitude. And yes, they want to cure their child's cancer. There's an element in every one of these parents that have been intolerant of what the expectation is and the desire to contribute to avoid that same type of tragedy for another group of parents. And that's a remarkable element of pushing forward this idea of innovation. It's really as altruistic as you'll ever see in a human being.
Yeah. So are these trials only being conducted in New York, or are they elsewhere throughout the country?
Well, I'm happy to report right now the clinical trial that I'm running is only available through the work that I'm doing at Memorial Sloan Kettering in New York. But as of this week, I just got some very good news, and that is in our attempt to roll this out into a national format through what we call a limited consortium, a group of institutions that have the infrastructure to conduct such a high-intensity clinical trial with a lot of demands made on it. We have basically just gained approval through that consortium, the Pediatric Brain Tumor Consortium, the PBTC, to move forward, submit this to different organizations for oversight, for regulatory oversight. So the protocol, by and large, has been approved by that scientific community to roll forward. So I would expect that in the next couple of months, we'll have that protocol drafted and ready for review in the hopes that within this year, it'll be available through select institutions within the United States to allow greater access to such an innovative approach.
So great progress to hear that.
Oh, yeah, it's wonderful progress. It's overly time consuming.
Yeah.
But it's interesting how a clinician gravitates toward an element like this, especially a surgeon, where this is not classically speaking, a surgical disease. That I tell you, the motivation is really dictated based on interfacing with parents and feeling that sense of gloom and desperation. And that is really the inciting and driving force behind us. It really is.
I was going to ask you what advice you could give to, up-and-coming medical students who may think that this is a pathway that they want to take, but I think you kind of just hit the nail on the head that, you get that drive from the parents and working with them directly.
Yeah, the person who's young in their career and earlier in their career, I'm sure it differs for each individual, but the advice I would give is to adhere to what your belief is. There's always this concern, and I still, to this day, share the ambivalence about moving forward down certain paths that are highly unconventional, highly innovative, and potentially injurious. And there's been a fair amount of, I wouldn't say criticism, but caution as far as accepting and embracing this type of idea. And for an individual to go out alone and propose such a therapeutic trial is challenging, and it challenges your persona, challenges your dedication. So the advice I would give is, if it's scientifically got a solid foundation, and one should adhere to that idea and drive and commit themselves to it. And this is not easy. It really isn't easy, emotionally, practically speaking, financially. So all of these elements, one needs to be extremely, extremely adherent to their belief and continue to move forward with what they believe inherently is a good idea.
Absolutely. Wow. So lots to think about there if this is something that, like we said, the up-and-coming med students are interested in. Doctor, I hate to cut you off, but we are just about out of time. Any closing thoughts before I let you get back to your weekend?
I think the closing thought is for the community at large to remain unbelievably optimistic. There's so much great science. There's so much great advancement that's going on. And we have watched over the past 50 years certain pediatric cancers become fully curable. And my anticipation is we'll continue to check those off as we move forward.
Absolutely. Well, I welcome you back on our show, Dr. Mark Souweidane, Vice Chairman for Neurological Surgery Department and Director of Pediatric Neurological Surgery at the Weill Cornell Medicine, Brain, and Spine Center in New York. Thank you so much for your time.
Julie, it's been a pleasure. Thank you for inviting me.